So our next panel here, so in addition to childcare, rural communities often lack access to healthcare services. The rise of telehealth, especially during COVID-19 pandemic, has established this care as a model and as a key tool in providing access to a wide range of healthcare services throughout the West. Western governors are working to expand the use of telehealth to ensure that all residents have access to healthcare beyond the end of the public health emergency. Today, we will hear from a panel of experts and passionate telehealth advocates will speak to these efforts, including how to increase telehealth usage and adoption and ways in which telehealth is transforming the healthcare system. It is my pleasure to introduce our moderator, Dr. Lisa Finkelstein. Dr. Finkelstein is a semi-retired urologist from Jackson, Wyoming, and the medical director of telehealth at St. John's Health. Dr. Finkelstein currently serves on the board of the Wyoming Telehealth Network and the Northwest Regional Telehealth Resource Center, as well as the American Urological Association Telehealth Task Force. She is passionate about teaching medical students about telehealth and has presented many times and been featured in several articles about the topic. She's a true champion of telemedicine and believes that this is the new way of practicing medicine is here to stay. Dr. Finkelstein?
Thank you, and thanks for inviting me. This is really exciting. It's kind of a new venue for me as a physician. As Jack said, I am Lisa Finkelstein. I'm a urologist, and I am originally from Philly, trained in Michigan, stayed there for 15 years, and then jumped off a cliff and moved to Wyoming, which I didn't even know where Wyoming was on the map. And so when I told my mom I was moving to Wyoming, she's like, "You're what? Wyoming?" And a lot of people say, "Are you moving to Miami?" Somehow Miami and Wyoming sound the same. I don't know. Let me start by saying I love telemedicine. And I'm going to tell you why, and our panelists are going to give their examples of why they are telemedicine champions. So when I moved to Wyoming and jumped off the treadmill of 5 offices and 6 hospitals and running around, not knowing who was living, who was dying, who was leaving, who was coming, and jumped into rural medicine and practicing urology, it was very eye-opening. And in order to grow my practice, I was a solo urologist for over 20 years. I flew on a twin-engine plane to Rock Springs twice a month. I drove to Pinedale twice a month, 75 miles each way, through Hoback Canyon, you know, Snowmageddon, avalanches. If I couldn't get to my patients, it could be a month. If my patients couldn't get to me, it was really, really hard. In 2010, about 2010, we he just retired, a wonderful Medicaid director in Wyoming, Dr. Bush, who's internal medicine, who had a vision. And the vision was telemedicine. And he had the forethought to form the Wyoming Telehealth Network, so I became active in that, and also bought 500 HIPAA-compliant Zoom licenses for any physician that wanted to dip their toes into telemedicine. In 2010, it was not ready. Technology wasn't ready. You know, you get on a camera and the fax machine would run, and then the camera would go down and the computer would go down. In 2018, there was a few of us that took advantage of the HIPAA-compliant Zoom licenses, me being one of them. And the CEO said, "Lisa, if you can make it work, go for it." So I'll just give you the example of my first patient. She's in her 50s, she has multiple sclerosis, she can't walk, she can't drive, and she can't pee. So I had to work her up physically in Jackson. She had to drive over Togody Pass to get to me. I did cystoscopy, urodynamics, worked her up. And then I had to teach her how to perform intermittent catheterization to empty her bladder. And I asked her if she would be willing to try this telemedicine thing in Du Bois, which is where she lived. And that was it. That was the game changer. So that was pre-pandemic. So one of the barriers that we're going to talk about is physician buy-in. And because the patient, you know, if you said to them, you don't have to drive through Hoback Canyon, it was, you know, a no-brainer. But the physicians, I could not get them to understand what telemedicine was. So I say this not to offend anybody, but thank God for the pandemic. So even though it was a horrible, horrible thing that happened, as they say, don't let a crisis go to waste. And telemedicine was one of those things that was a shining star of this horrible event. So what it did was it triggered this innovation of telemedicine, and literally in 2 days, those physicians that had said, you know, no way, Lisa, were calling to say, how do you do this? So that's my story, and that's why I love telemedicine. And we're going to talk today to these experts up here on the panel about how to open up the digital front door. And the digital front door is really a strategy of, I think an analogy that I like to say is, if you walk through a door and you've got hallways to choose from, and you're going to go right or you're going to go left, the digital front door is not actually a physical door, it's a virtual door. But now the innovation is, it's not about me as the doctor. As Dr. Rhone can attest, physicians are spoiled. We want our patients to come to us. We want them to drive through the pass and come and sit in front of us. But now it's not about that. It's not about the doctors. It's about the patients. And how technology has made healthcare accessible for everybody where they are. And when I first started utilizing telemedicine, the requirements and the barriers were that the patient had to go to a rural clinic to sit down in front of a computer that had reliable internet to engage in telemedicine. That barrier right now, and we need to ask Congress to make this permanent, is to allow that restriction to go away, and we can now perform telemedicine anywhere. So the best, in my mind, pre-pandemic was in their home. Well, now, as we're going to talk about, it can be in an ambulance, it can be in a home, it could be in anywhere where the patient is. So the paradigm is being flipped on its head. So there's a lot of resistance here because me as a traditionally trained physician that loves touching people, I'm a very touchy person, we have to change our perspective. And that's really hard for a lot of doctors and providers. It's even hard for medical students. I teach third-year medical students, and they're still struggling. So we're in this really interesting time right now. We're on this, leading edge or bleeding edge of the wave here. And we're going to talk about different innovations in telehealth. I don't think we need to start from the beginning of what telehealth is because everybody understands it. So I'm going to stop here, and we're going to have our panelists introduce themselves. And our first wonderful person is Nikki. So Nikki, you take the ball.
Thank you. Thank you, Dr. Finkelstein. My name is Nikki Chopsky. I'm a pharmacist. I am from Idaho. I work at the Division of Occupational and Professional Licenses as a bureau chief, and I'm the executive officer for the boards of medicine, nursing, and pharmacy in Idaho. I'm going to talk to you a little today about our perspective or our approach and what we've done. And I've kind of broken it into 3 sections: where we were pre-pandemic, where we were in the middle of the pandemic, and sort of where we are as the pandemic wanes and legally we come out of it as these public health emergencies end. So first of all, the Idaho Telehealth Act was actually established in 2015. As we got closer to the pandemic, We were actually well positioned headed into the pandemic, and that was because our lieutenant governor, who happens to now be our governor, had already had an initiative on licensure freedom and red tape reduction and looking at what we could do to remove barriers. So our boards were already thinking in that direction, and we had already worked on ratios and supervision and some of the big topics, remote work and those kinds of things that a lot of states had to juggle or struggle with as the pandemic hit. In 2019, there was a Healthcare Transformation Council of Idaho formed through the Department of Health and Welfare. This telehealth task force completed their charge in 2020 with a strong list of recommendations. Some of that tried to translate into legislation that did not pass. There were a number of bills, in fact, that were brought before the legislature in the years that followed, most of which failed, mostly because they only took into account one perspective, either the perspective of the industry or the perspective of the regulatory boards and their associated professional associations, which have a strong viewpoint on these things. So shortly after the pandemic hit in April of 2020, our governor waived a number of licensure requirements to increase the capacity of healthcare professionals, and some of that was at the grave concern of a few of our licensing boards. Some of our licensing boards did ask for voluntary notification or registration. If you were going to practice into Idaho without a license, but you have a license in another state, would you at least tell us you're here? And we kept track of those numbers, and there was quite a bit, in the thousands, which is a lot. You might know or might not know that Idaho ranks 50th in physicians per capita. We are at the very bottom of we need a lot more doctors where we are.
We're probably number one.
Okay. 3 months later, or 2 months later in June, Governor Little asked for the boards to consider any restrictions that had been relaxed or removed to be made permanent, and that boards take action to do that. And some of the boards struggled with that, but ultimately we are an executive branch agency, all of our boards are, and so we did work through that. In 2021, the legislature removed some of the authority of the governor to waive statute. And so while we had made progress in the rules, it did take us a couple years to get the statutes where they are. I know one of the things that I was asked to provide, and I did not bring a slide, but just for scope, in late January of 2021, our Director of Health and Welfare was on record as saying telehealth behavioral health visits between March and July of 2020 increased 32,059%. And that's comparing March through July of 2019 to March of July of 2020. Medical visits overall were up at Medicaid 12,681%. So Medicaid is only one payer. We have lots of private payers. I don't have the stats on all the private payers, but I assure you that in all the meetings I've been in, they had similar type crazy exponential in the 1,000% increase percentage of usage. So. In the interim, what happened, DOPL issued on September 9th, 2021, a COVID guidance. And basically, the governor was, obviously the legislature had spoken. The governor was not going to be allowed to waive statute. We'd done what we could with the rules, but some of this stuff was in statute. So we ended up providing a guidance document that said we were going to use enforcement discretion because we were still under the federal declaration of emergency, and there was still a state declaration of emergency too. In order to continue to increase capacity and maintain what we'd gained in the time that those were waived, we were going to provide enforcement discretion on the topic of telehealth into Idaho. We continued to update that guidance. We updated it in March of 22, August of 22, January, and then again in April. And there were some considerations that were in there. You had to be licensed and registered in another state or jurisdiction. You had to be in good standing with no pending discipline action. You had to act in good faith and exercise reasonable care. You obviously had to follow any federal applicable laws. You had to possess the necessary education, training, and experience for the services you were going to provide. And you had to use sufficient technology to establish that patient-provider relationship. Eventually, in this past legislative session, we were able to get a bill through. I'm going to talk more about House Bill 162, now called the Virtual Care Access Act. But what that allowed us to do, and what we did at the end of January, was we updated our guidance to allow for early implementation. Actually, it was in April, to allow for early implementation of the new interim, or the new Virtual Care Act. And we highlighted 4 points, and I'm going to hit those as I go through the act itself, so I'm not going to hit those now. But what I do want to say is, while the use of telehealth expanded greatly, what we did not see was we didn't see complaints or discipline expand greatly, and certainly not in a proportional manner. So the question of, is this safe care? You know, so I mentioned some of the boards had some grave concerns about who are these people coming into our state and providing this care, and are they going to do it the same way we do it, and that kind of thing. We didn't have patients complaining. Our complaint system is based, and our investigation system is based on complaints. So I do want to kind of put that out there. With just a couple minutes that I have left, I do want to talk about, as the pandemic has waned, how we moved forward. So there was a task force or work group, I'll call it, put together and led by the policy liaison, health policy liaison in our governor's office. And she was pretty clear with us that the goal was to get a bill that the governor could sign without being at odds with one group or the other, because there seemed to kind of be at least 2 camps, and maybe there were even more camps on where we should go with telehealth in Idaho. And he didn't want to be in a position where he was being asked to veto it by one group and sign it by another group. So she said, we really want to get something that we can all agree on. And so that work group included industry advocates, both at the national level and at the local level. Our professional associations, I'll specifically call out the Dental Association, the Medical Association, the Pharmacy Associations. We also included our hospital association, who had been trying to bring in respiratory therapists and intensivists and people to work in ICU, particularly during COVID. And of course, DOPL, as the regulatory boards, had a seat at the table. What we ended up with was one practice overall for all health professions in Idaho. We're not going to battle this in physical therapy and then battle it in psychology and then battle it in medicine. We just made one act that will cover all the professions. We have no technology modality restrictions. So there's a lot of talk about you had to audio, video, audio and video, audio or video, that we don't have any technology modality restrictions. We do have some commonly accepted licensure exemptions that I'll call out. And we did establish, this bill did establish where the venue of care is, and that's important when it comes to the concerns related to discipline and enforcement. So what we landed with was the Idaho Virtual Care Access Act. It was House Bill 162, if you want to look it up. There's kind of 2 parts to it. The first thing that it touched was there was a statutory definition in the Pharmacy Practice Act called the validity of a prescription drug order. And it already stated that in order to write a prescription, it had to be for a legitimate medical purpose, which included a patient evaluation adequate to establish diagnosis, identify underlying conditions, and any contraindications to treatment. What House Bill 162 added was that the relationship can be established through virtual care technologies as long as it satisfies the Idaho standard of care. And then there were already in that section 9 instances where a valid patient-prescriber relationship does not need to exist, and that's like when you're covering on call for your colleague. If you have the first visit and you need to write a prescription, they're scheduled for an appointment in 2 months, but they can't get in because they have to drive through the pass. So you could prescribe ahead of that. Emergencies, and then supervisions of others if you were signing off on a prescription for a PA or a nurse practitioner that you oversee. The call-outs that treatment was based solely on a static online questionnaire does not constitute a valid patient-prescriber relationship, and I think that's important. It was important to the stakeholders that a static online questionnaire does not constitute a valid patient-prescriber relationship. So I don't have much time, so I won't go through all of them, but I do want to say in the definition section, there's probably 3 important things. We defined provider, we defined what a static online questionnaire was, and we defined virtual care. So we're switching from calling it telehealth to virtual care. And in Idaho, that means technology-enabled healthcare, and it can be synchronous or asynchronous, and care is considered to be rendered at the patient, at where the location of the patient is at the time that the act is provided. We did deal with scope of practice, and we said that that scope of practice has to be within the provider's license and is subject to all laws and has to meet the Idaho standard of care. You'll see that Idaho community standard of care many times in the statute. For prescriptions, it did not expand or restrict what is already allowed by licensure boards. So if the thought was, I'm a prescribing psychologist, but my state doesn't allow it, but Idaho, you're limited to the same thing that you'd be allowed by the licensing board of our state. Continuity of care, so folks that established care ahead of time and then tried to do follow-up care across the state line. You said Du Bois, Wyoming.
Wyoming.
I'm thinking Du Bois, Idaho.
Right,
I was like,
right.
oh, she's providing telehealth into Idaho. Providing the continuity of care piece, one of the stakeholders groups really felt strongly about the fact that the provider had to give a method of contact for the provider of record. So there had been some opposition in that these folks who had received teledentistry, if I throw it out there, that they could not get a hold of the provider later if they had questions or problems. And so that is called out in the statute. Discipline, you must be in compliance with our state and federal laws and the Idaho Community Standard of Care, and state licensing boards are authorized to enforce the chapter. Services are deemed to occur at the location of the patient, as I mentioned. And then those exemptions, real quick, I want to call them out and I'm out of time. The exemptions are that you must be licensed by our board except if you have an established patient-provider relationship with a patient that is in Idaho temporarily for work, business, vacation, or education. So you're a Montana physician, your patient comes to Idaho to go skiing, gets a cold or whatever and calls you, you don't have to have a license to practice into Idaho for that. Your patient's in Idaho, but they're leaving to go back home to wherever they live in a temporary manner. You've established a patient-provider relationship for temporary or short-term follow-up. We have a lot of folks that go to Utah for cancer care, and then they come back to Idaho and get follow-up care. That Utah physician would not have to register in Idaho for that. Is employed or contracted by an Idaho facility to provide services that are in a facility that privileges or credentials. So this is kind of a new one, or was newer, I would say, of the exceptions. But if the facility, so this is locum tenens, this is like bringing folks in an emergency. If you provide credentialing and privileging in your facility, they don't have to hold an Idaho license. They just have to hold a license in their own facility. Rendering health care in time of disaster and providing follow-up care, and then providing health care ahead of a scheduled visit, which I kind of mentioned. Consults with an Idaho provider, if you're referring somebody into our state, does not require licensure either. And folks that don't require licensure are exempt by one of those exemptions. By engaging in virtual care, they are consenting to our applicable laws and rules, our Idaho Standard of Care, the jurisdiction of our courts, and our licensing division and our licensing boards. And that's the authority that we need to take action if we do have somebody that's going rogue, if you want to call it that. What's not mentioned in our bill, and I think is important to say, is that it also removed rulemaking authority from our boards, which is in part why we had broad stakeholdering. Prior to this bill, individual boards could make additional telehealth regulation on top of this act, or on top of what we had on record from 2015. And this bill removes those boards' authority to do that, and so this bill really had to have stakeholdering from a lot of professions, because we're only going to have one act, and boards aren't going to be able to add rule to this. So with that, I'm 3 minutes over, and I should stop.
Wow, you know what? I am so impressed because that's an example. I really did not know all of this, and this is great information to know. What I often say is telemedicine is medicine, and so it's not that we have to change everything to make it different for telemedicine. So teleneurology and teleaneology is the same in Wyoming, should be as the same in Nevada, but we struggle with licensing. And so what Nikki just went and said for Idaho is fantastic, but is that true in California? You know, and so if we have a patient that is from Wyoming and then winters in California, then it's on the physician to find out what the latest bill is in California that they've revised in January, to look at the exemptions of, is it okay to see my patient in California if they're there for 2 days or 2 weeks? And so that's something that we can talk about. And Dr. Kelly Rhone is she's an ER physician and holds 20 licenses. And so it's a great example of the hurdles of multi-state licensing for physicians and the burden. But Kelly, introduce yourself and tell us your perspective from Avel eCare.
Thank you. First of all, thank you so much for having telemedicine on this agenda and allowing us to come and speak. It's really an honor. I'm Dr. Kelly Rhone. I am South Dakota born and raised. I still live in South Dakota. And got my start as a volunteer rural EMT in Clay County, South Dakota, as I started going to school. So that's where I kind of got my love for rural health and my love for emergency medicine. So did my training in the Twin Cities, Minneapolis, St. Paul. And then I spent almost a decade in the tropics of Nebraska. Because I was there, you have to become a Huskers fan, and you know all that comes with that, and the pain and all of it. But then I was really called home to South Dakota, and one was because the grandparents were all there, but really they were starting this really cool program in teleemergency, helping rural hospitals, and it was an opportunity that I still got to work in a trauma center and do all the really cool, fun things that emergency physicians get to do. But I also got to spend part of my time really helping rural health take care of emergency patients across multiple states. So I went to work for a health system called Avera Health, and now that telehealth company is now called Avel eCare, and we went private in 2021 after we grew well outside of the health system's margin, and they decided that we were basically big enough to go off onto college and be on our own. We went from being being owned by Avera to having them be one of our biggest customers. But I want to take a little bit of time to really make you think about telehealth in a different way. Most of us think about telehealth and telemedicine as an appointment with a specialist, and it absolutely is that, and that's such an important part of telemedicine. But it also is seeing, just like Dr. Finkelstein was saying, it's really about patient-centered care and bringing the experts to the patient in the time that they need them. And so most of our programs are actually 24 hours a day, and they go out to where that patient is. And one of our big goals is to keep the patient locally when that makes sense, but also to help those local providers to take care of patients in the communities in which they live. And the other thing I would say is if you've ever been to a rural community critical access hospital or a frontier hospital, if you've been to one, you've been to one. They're all very, very different in what they can do. I take care of patients in some hospitals that at night I cannot get an x-ray. So maybe taking care of a stabbing patient and I can't get an x-ray, right? And some that you can get an MRI at 3 in the morning. Those are very, very different areas. And so the people that work with us have to be able to go from one to the other very seamlessly and sometimes within minutes. So we have multiple programs. Again, a lot of them are actually hospital-based. So we call ourselves a virtual hospital. We started out with those basic consults 30 plus years ago. We've been doing this for a long time. When you're from South Dakota, you have a lot of miles that you have to go through with a lot of weather, right? And so we knew very early on that we were going to have to use technology to be part of our story. So as part of that, we were as broadband kind of expanded, one of the things that we did very early on was telecritical care. So we were bringing critical care physicians into ICUs across our miles to help local physicians and local nurses to be able to care for those really sick patients and have critical care consults, and then to also help those physicians and nurses there to have some work-life balance. When you work in rural America, you are usually covering clinic during the day, you're doing consults, and then you're probably on call at night. And so we can take some of that load off of them when they need to have some time with their own families so that they will continue to live and work and see patients in rural America. So a lot of this is actually about recruitment and retention as well in our rural areas. So that was actually going swimmingly in what many of our partner hospitals said, we really love what you're doing in the ICU space, but I don't really keep ICU patients because I don't have an ICU. I'm a small hospital, but what I really need help with is in our emergency departments. So we started a teleemergency center. We had some really nice grant funding in order to be able to do that, but we were tasked with saying, you can do this in your 4-state region, but you have to grow it outside of that in order to be sustainable. So we knew that we were going to have to, because we also needed to make it affordable, because rural hospitals have very tiny margins. And so we had to be able to do it so they could call us anytime, 24 hours a day, and we would give them emergency nurses and board-certified emergency physicians, no matter the size of the hospital. And so we're in some hospitals that are frontier, sometimes don't even have a provider part of the time. Many of our hospitals at night, that provider, whether that's a PA or nurse practitioner or primary care physician, they're home at night and are called in. So we're working with those nurses until they get there. Or if they are there, we're helping them to manage those patients. So we see a lot of the big, bad, and ugly and help them walk through those patients. We see at least 3 cardiac arrests. We do emergency airways every day. I've now, God forbid, delivered more babies over a camera in places that do not deliver babies. We just delivered breech twins. So, I mean, things like this in very small hospitals that people just end up in. You can have all of these terrible things that you think of that happen anywhere in our country, right? You can be part of a 3-car pileup, you can have an MI, you can have a stroke, and having those experts come to you and help that team to manage that is really, really important. We also do telepharmacy, so having pharmacists available to those hospitals. We have telehospitalists, so inpatient care, which was really important during the pandemic. Our small hospitals were really a huge part of our safety net during the pandemic, and some of them that normally would keep an average daily census of 3 were keeping an average daily census of 20 or more. And these were really sick patients. Many of those hospitals had never had a vent before, and so, the state maybe rolled in a vent, but no training, right? So we were blessed to have also respiratory therapy as part of our program and being able to offer that as well. And then behavioral health, of course, doing behavioral health assessments on patients who are acutely suicidal in emergency departments, and having behavioral health nurses who do this every day to do that along with psychiatrists, so that if a patient does not meet and does not need to be admitted, we're still giving them treatment, and then we're setting them up with the local area either therapy or resources in order that they continue to get care. And one of the things that was really cool about that, we said, we've been doing this in emergency departments for a long time, but one of the kind of stakeholders in behavioral health are our police officers, right? And they don't feel comfortable. They're very good at de-escalation, but they do not feel comfortable making a lot of those calls. So we are now in the back of police cars on iPads, doing behavioral health assessments in patients' homes, or in a park, or wherever we're called to be there. And then we can do that behavioral health assessment, and that patient is not criminalized for their behavioral health problem. They're not put in handcuffs and put in the back of a police car and then taken to an emergency department. And 80% of the time, we're able to keep them at home and then set them up with local area resources, and the ones that need to be taken care of in a higher level of care, we're able to help them do that. We also do school-based care, which is amazing. School nurses, I just have such a love in my heart for them. and then work in nursing homes and assisted living centers as well, who have had such a staffing problem. It's been just before the pandemic, but since the pandemic, really difficult for them to find staffing. And then I would also like to just say that telemedicine is not just provider medicine. It really involves the whole spectrum of care. The last 6 to 9 months, you've probably, and if you haven't, you will have heard a lot of stuff about virtual nursing, right? Virtual nursing, that's something that we have done for, since the beginning of time. Very early on, we thought this was all going to be physician-based, and what we realized that, I guess we thought we were really important, and what we realize is that nurses are really important. And the other thing that's really amazing about nurses is they are really good team workers. And so they actually adopt telehealth probably better than physicians. And then they're the ones that are saying, if you turn this off, I'm out of here, right? I'm not going to stay in rural America. So they're the ones that actually bring the physicians on and help to get us that buy-in. That we'll probably talk a little bit more about buy-in, but it is really helpful to be able to go out there and help nurses to do their work and take the load off of them. So again, we want people to stay and live and work in rural America. So I'll stop there. I'm sure we're going to talk a lot more about different things that happen, but just to kind of give you a piece that is maybe a little bit different than telemedicine that you have typically thought about.
Wow, that was pretty unbelievable. It's a great example of a system that offers so many different services. A lot of people aren't aware, again, the digital front door of what is available. Our next speaker is Jody, and Jody and I sit on the board together of the NRTRC, and Jody's the director of telehealth and the Eastern Montana Telehealth Network in Billings, Montana. So take it away.
Great, thank you, and thanks again for allowing us to be here and share the telehealth buzz. I think you all have probably heard of it since the pandemic and when that started, that it just kind of exploded, or as my husband says, as I've been doing this for 15 years, careful for what you wish for, right? But it's great, it's exciting, and it's awesome to talk about it to a wider audience of what the impacts that we can have and the outcomes, especially in that clinical care spectrum, for patients everywhere, right? And so traditionally, prior to the PHE, we've learned with telehealth, there was really some tight guidelines in which the ways we could deliver care. And you do that for a while, and then you see the pandemic happen, and boom, it explodes, and there's this big opportunity. So now the question mark is, should it continue, and what does it look like? And so here for that conversation all day long. As Lisa mentioned, I am originally, I guess you didn't mention that, sorry, we changed tracks. I'll mention a little bit about myself before I get started. I'm a fifth-generation Montanan, born about 3.5 hours east of here on a cattle ranch. My mom was a rural provider and would go see her patients, out in the rural settings, sometimes make house calls. And if you remember back in the late 80s, early 90s, there was Senator Conrad Burns, was from Billings as well. I actually knew him as a cattle trader and a really good auctioneer when I was very young. But he also started the Northern Egg Network, and my mom would say, you got to come with me. You got to come with me and go to see these patients. You got to see all these nooks and crannies of where we're going and what we're doing. And so he would. He'd go along, and then he'd go back to D.C., and he was the best proponent for telecommunications for back here in Montana. He funneled a ton of money back here to set up rural broadband. And you got to give it to him for being a huge advocate from day one for rural health care and allowing telemedicine within the state of Montana. So with that, I obviously work at Billings Clinic. I'm in charge of our virtual care, telehealth, digital health. That's an ongoing conversation. I noted that down just because the definitions, we're all speaking the same language, but we call it different things, right? So we did it to ourselves, but again, the opportunity is boundless and in front of us. So across our enterprise, all sorts of digital care, the front door, how that works for patient access, but also the Eastern Montana Telehealth Network, which has been around for 30 years. So 1993 is when that got started. We have a big to do later this year to celebrate the 30 years young. Currently, we beam out over 40 specialties to 43 locations across Montana, North Dakota, and Wyoming. I'm truly passionate about rural and frontier. Thank you, Dr. Rhone, for mentioning the F word, frontier. Less than 6 people per square mile. We count, we matter. So thank you. I'm really excited about the work we get to do. We really started off from an educational perspective, but about 20 years ago, quickly saw the need for more clinical. And so we've really shifted gears to get more of the telemedicine out to each of those sites. Now we're at a whole new launch pad, right? So post-PHE, where we're going to go from here, there's been a huge need for acute services, emergent services, and how do we talk together, right? Because we still have those disparate EHRs and the talkability or the stackability of the tech, the services, the providers, the components, the legalese, the services, the billing, the coding, all of that mumbo jumbo has to come together. And so we're really looking forward to our development of what we are working on within our infrastructure across the state. We were funded recently pretty heavily to put in some new infrastructure across those sites. We also have the USAC program that is federal that also supports a lot of our sites as well from a broadband capacity. That's been really a good thing for us as we've grown over the years. The models of care in rural and frontier are so interesting. I love, you see one, that's truly what you've seen is one critical access hospital. Everyone works so different. So the customization that telemedicine can provide and all the trickle effects of that, including staff retention, staff retainment, are so huge. And so we really take pride in customizing the services that we provide for each of those locations based on the services that that community wants and where they want us to be. So we're not a one-size-fits-all, here's the program, here's the service. It's what works for your community, let's tailor it, and then let's make it work, right? The outcomes. And starting with the patient care are first. With the PHE just across our system, holy cow, buckle up, right? Everything literally changed so fast. And we saw a huge growth for those emergent needs that were locally based and locally sourced. Article after research paper will tell you patients want that relationship to continue with their PCP. That's who they trust the most. Not through, sorry if there's any providers in the room, but they don't trust that as much as their normal PCP relationship. And so we saw the need to get directly to our patients without having to outsource any of that. So as you can imagine with the direct-to-patient telehealth, it exploded, all of our numbers went crazy. We still average about 8 to 10% of all of our system visits via telehealth, and that excludes our network pieces. So that's directly, that's just direct-to-patient telehealth is that number there. So that's pretty impressive. We continue to grow within the consultative mode, which is pretty exciting. Again, what patients want, where they need them. Is it, PICU, NICU? Are we having babies in little areas? And they just need some support. Tele-ICU is another great one where the nurses just love it because they can stay there and they can see those patients that they typically don't see, right? So it's pretty exciting to see that and support those rural markets because a lot of times these critical access hospitals are the largest employer in their town. I think lastly, I would end with some work that I do. I do quite a bit of volunteer work, and one of them started as a labor of love in late 2019, prior to the pandemic. It was House Bill 43 that ultimately was passed by the Montana legislative session in 2021. That thing has been amazing. So for Montana, that has allowed us to include the definition of audio-only telehealth into the definition of telehealth, and so that really helps for those rural areas where they don't have the capability to have the audio and visual connection. If it's efficacious, they can have that visit via audio-only technologies, which has done wonders in the behavioral health world, as well as getting those providers into those patients to have them seen from their homes, right? So we're eliminating those barriers to be seen. So that was a huge win for us. It also eliminated that requirement for an in-person relationship. It also set forth the continuation of the home as an eligible originating site, which is huge, again, to continue forward with that. So we're really excited about that. It passed unanimously through every reading and also through every vote. So I'm not for sure which one said it, but one legislator said, gosh, I don't think you can pass a bill on huckleberry pancakes through unanimously anymore, but we'll take it. So that was a huge win. We also had Senate Bill 357, which provided some parity for us with Montana Medicaid, and I've got to get a shout out. I'd be remiss if I didn't for all the years we've worked with Montana Medicaid, and they have been phenomenal. They understand that if that patient doesn't get that care in those rural areas, they're the one on the hook for paying for them to get to that higher level of care, which sometimes means a lot more or a negative outcome for the patient. So they have been phenomenal. We really appreciate them. But Senate Bill 357 was for us. I'll touch really briefly, too, on what we thought we had in the bag. 10 years ago, Senate Bill 270 was a parity rule for Montana. The way it was written apparently has wiggle, so we thought we had payment parity or reimbursement parity and service parity wrapped in there together. Come to find out, there's wiggle. So this last legislative session, we took a swing at that, looking at the one that was probably leading that charge here right in front of me, but really tried to go back and take another swing at that reimbursement parity because it's so important for those patients that can be seen, that they can continue to get that care where they need it most and when they need it most. So we'll take another swing at that, but we'll also continue to fight for that definition that we thought we had in 2013. So more to come on that. I'm not for sure. My time. I'll stop there. Sorry. Thanks.
Yeah, this is incredibly complicated. So we're going to, well, let me just ask, are there questions from the audience? Because I could throw out, 20 questions. Do we want to, right behind Lauren?
You had touched on parity and cost. In California, many of our rural hospitals are suffering because Medicaid isn't keeping up, plus a number of other factors. How cost effective has the introduction of virtual, whatever health we're talking about, how has that played out for the hospital facilities in these small communities?
I can take a first stab at that. So with the federal PHE, we just got to go through the big unravel project, as we called it in our health system, with May 11th, right, last Thursday. So with that, that provided some provisions for facility and non-facility based payment rates that was on par as if the patient would have been seen in person. Now we've reverted back, and so we're actually seeing a lower rate than what we would have as if the patient was in person. And so that reimbursement parity piece is super important when we talk about that, because we're being paid at that non-facility based rate, which therefore is lower, and it depends on your state, depending on what that percentage is, than what you would be if that person was in person, or if that patient was seen in person. So that's reverted back now. So all of those things are now in place again. So we'll need some more action federally to look at that. But also the Q code, the traditional, the legacy telehealth, right? That started off, oh gosh, fun fact. Maybe trivia question. I'm blanking on the year exactly, but it started off at $20 even. And every year it went through the incremental raise, right? I think we're at $27 now. For the facility side, so from the eligible originating site to be able to drop that code in addition to the pro fee side, right? So that should cover that side of it, but we all know in all of these rural sites that does not cover that nurse's time to be there to telepresent and sometimes validate reads back to that provider on the other line that spends their whole time with that patient in the room, and then also has the AV equipment or whatever the modality is to connect back. So that's a big topic, but I'll try to stop there.
I'm going to just summarize a little bit what Jody just said. So I was in Washington a couple of months ago talking to our senator and some of our legislators. We were there with the AUA, and we had 5 things that we asked for from our federal government to try to help us make permanent. So, we represent different states, and that's why this is so confusing, because, state by state by state has their own set of rules and regulations, but we really need Congress to make these things permanent and not keep kicking the can down the road, so to speak. So, payment parity, where we need to be able to be paid the same amount that we would get paid if the patient was seen in person, not this fluctuating amount. And the adage of a physician sitting in a closet wearing a T-shirt, holding a cell phone, giving advice is not realistic, because we now know that telemedicine requires so much more really even than inpatient, because we now need technology and platforms. We may need an IT support person. We need broadband. We need staff to onboard patients that don't understand how to use the technology, that don't have digital literacy. That takes time. We need our EHRs and our computer screens to get up the information, the images, the labs. You can see that it costs a lot of money to make telemedicine work. I mean, Jack was giving me an example he gave me permission to use with his girlfriend who was trying to access telemedicine and was having difficulty because her doctor could not get the imaging or the lab results or the test results on the screen at the time of telemedicine. So the point is, we need payment parity. We need the originating site barrier to be made to go down permanently, and we think that that will happen where they don't have to go to a clinic. Remote supervision, where we can watch other providers perform things utilizing telemedicine, needs to be made permanent. Audio only, we also need to be able to provide as a true telemedicine visit and make those changes permanent. Real quickly, I just want to add that it's becoming so complicated now. We have the ability, as these guys know, to utilize what we call peripherals out in the field. So we have tele-stethoscopes, tele-otoscopes, high definition cameras. We have ophthalmologic equipment that sends unbelievable images. Radiology has been using telemedicine forever. We have pocket ultrasounds that physicians out in the field and in the back of ambulances and in ERs and in the wilderness have the ability to put their image on a cell phone and utilize telemedicine to experts that can read these images real time, ultrasound, potentially look at pulmonary embolism, so these are highly skilled physicians. So it's really endless, and we need our legislators and our policymakers to understand how big this is. We didn't even touch on AI. I wanted to ask, we have 15 minutes, these guys, if AI is on their radar. Can we talk about that real quick?
Sure. I could try that. What I will say about our act is that it allows for technology-enabled healthcare, and it's worded that way because we're not going to be able to keep up with all the new devices and things and types and ways to do it. And so I would say that ours would allow that. Now there's, AI is a big thing, and there's going to be probably some other factors or external limitations, I think, that will come as we learn more about how to use AI properly. But I think the best I've heard is it's just another tool. It's just another tool in your toolbox. It's not turning over all of the knowledge and skills and training that healthcare professionals have. It's just using another tool to enhance our ability to take care of patients. And so we don't have anything called out that will prohibit it. It's technology enabled, so I think it's permitted in Idaho. But I do think that as the market continues to develop, there will be external factors that do put some guardrails around that.
Full transparency, I use Chat GPT to ask what are some good questions to ask our panel. And it did a great job. Kelly.
I think, Lisa, that's exactly what we need to look at, is just making sure that we're not being too prescriptive about what can and can't be done in the future, because then legislatively, we need to go back and change it, and it just takes so much time. And, it really quashes innovation, and one of the great things about the pandemic is so many things that we had been asking for years, we all of a sudden got yeses across the board. Do it, because that we need, develop it, make it happen. I think, in 1950, medical knowledge was changing or doubling every 50 years, and right now it's every 73 days. So I don't know how you're going to, or I was just talking to 70 med students last week, how are they going to keep up without technology-enabled devices? And so, if you think about, and I didn't make up this analogy, but if you think about many cars right now, and if you go over the line, right, it buzzes at you if you go over the line, but you can still drive your car into the ditch if you want to, right? And so that's what I think about with AI. It's going to give us data and help us to think about what direction, if I have a 40-year-old female with a certain kind of cancer who also has hypertension and lives in Western Texas, what the best thing that data will tell you to do. It will give you that, but you will also be able to use your medical knowledge in order to do things. So I think telehealth has a lot of opportunities, and then I just want to take a minute to talk about, new innovations. And, our governor had really the I think, forethought of looking at EMS in the state of South Dakota, which is almost entirely volunteer-based. So most of these people are working at the hardware store or at the bank or maybe at the hospital, and the call comes in and they go. And we have not enough volunteers, and so she put together multiple different pieces that would help to support EMS in our state, and one of them was to put telehealth and real-time physicians and nurses in the back of ambulances in the middle of nowhere in South Dakota. And I was just talking to one of our patients from Kimball, South Dakota, who gave me permission to talk about this. He got gored by one of his buffalo. He's a buffalo rancher, so buffalo are not just roaming in South Dakota, but he was actually, caring for his animals, got gored, got thrown, was, 16 broken ribs, lungs full of blood, broken arm, broken pelvis, basically stab wound through his abdomen. And he said, the first time that I thought that I was going to make it was when I was talking to that physician in the back of the ambulance, and they told me that they had already called a helicopter, they already called the critical access hospital and let them know what they were going to need when I got there, and they already let the trauma center know where I was going to have to be. So we followed them, had cameras in the ambulance, in the critical access hospital, where we helped them to put a chest tube in that patient and resuscitate the patient, and then also in our trauma center in Sioux Falls, South Dakota. So that is continuity of care, and that's taking care of patients. And I told him I was coming here, and he said, please take me with you. So that's change.
That's a good story. Jody.
That's good. Yeah, I'd say the area with AI, we actually just have started. So I think the ink might be dry. I was on a call on my way here this morning about it, is within our diabetic population. So that's just a great place to start with anything innovative. We've done a lot of RPM, so alphabet soup, I realized that, but remote patient monitoring, that's been great for us, a good pilot to continually track and monitor patient glucose levels in tandem with not only their diabetic specialist, but also their whole care team. So they can continue to monitor them from at home, see if there's a spike, they can beam in, say, hey, did you have an extra piece of cake today after lunch? I can see your spike, are you doing okay? And follow the patient that way. So again, kind of more to the device side of telehealth, if and how the patients want it. I think that comes back down to a reimbursement perspective as well. But within AI, they are actually, the new company we're looking to partner with is out of India, and our CISO, so another acronym, sorry, Chief Information Security Officer, was on the call. So that was fun. That was really fun. That was about the first half of the call, was them figuring out how this is going to get to work with our with our electronic health record and the PHI and all of that information. But it passed all the tests, so all is well. So I don't have anything to report out right now, but it is on the roadmap. It's on the radar. It's forthcoming. And I would just say that it's being in this space for quite a while now, it's pretty interesting to see the change. I think before it was like, try this, I think it might work. And then now it's like they're knocking the door down. Like, let me try this, can we do that? How about this? And now it's more of a, we can for sure, but should we? Does that make the most sense for that patient population? And is it sustainable, et cetera, et cetera. So what a cool space we get to be in. I think we look back the last 30 years for our network's perspective and where we've come, and looking around the room and the place we get to go now the next 30 years. How cool. Well, my husband and I talk about going back to having just a landline at our house for our kids. So it's interesting the balance with the technology.
Yeah, I think it's going to get pretty weird out there. We won't even talk about the metaverse. So let's ask questions. Go ahead.
Thank you so much for the presentation. Again, Cody Stone with Montana State University Extension. Mental and behavioral health is of vast importance across the spectrum, particularly in some of our rural and frontier and tribal populations as well, so thanks for bringing that up as well. We've partnered with granting organizations with the Montana Department of Agriculture and have received some support through some grants for basically tokens for free psychological care over, virtual within that. Can you talk about any other examples that you've seen of success from either public-private partnerships in helping with that, or granting organizations that have helped perhaps bridge that gap between those that lack that type of service based on their location, and how we can maybe bridge that?
Yeah, I think, besides the fact that we've, partnered with, we started with the Helmsley Charitable Trust, gave us some dollars to start our project with mental health in the back of police cars, and that has now been taken over by the state and appropriations. But also we've been working with our tribal lands and IHS in the states of North and South Dakota, Nebraska, Wyoming, and Montana to do some behavioral health psychiatry, but also to do therapy. And one of the interesting things that we've been talking about audio only is, there's a very high no-show rate on tribal lands, and a lot of it is lack of transportation, lack of being able to get off work to go to your appointment, things of that nature. But once we took away the fact that they had to come to the clinic and they could do audio only, our no-show rate on our behavioral health programs cut in half. And so that was a really positive thing that the pandemic brought, but also now patients who are being seen for behavioral health are being seen regularly. And the other thing you have to think about in rural areas is they may have one or two behavioral health people, and in small areas you probably know them, right? You may not want to talk about everything to someone that and you're going to see in the grocery store, or your kids are friends with their kids. And so sometimes that little bit of anonymity of having someone far away is helpful. And I think one of the things that we really need to look at is the DEA is actually looking at, for those of us who prescribe controlled substances, which is really common in behavioral health, that they want to make you be able to see your patient in person at least once a year. So if you are in the state of Wyoming or the state of South Dakota or the state of Texas and you don't have enough, but someone lives in Boston and has extra time, right? They are never going to be able to see that patient. And so if they're seeing patients for substance abuse help and things like that, where they're using controlled substances, that is something that we really need to make sure that doesn't come. And, there are always going to be bad actors, but most of us, we saw that. We're not seeing a lot of abuse. And the DEA actually spent gave us 2 months for people to write in about the change that was supposed to happen last week, and they got 84,000 letters about why that shouldn't happen, and they put a pause on it. So we don't know what's going to happen there, but for behavioral health particularly, but everything else as well, making sure that access to care is not taken away because of that. So I'm not sure if that totally answered your question, but I think, those are things that have had a positive aspect in our behavioral health particularly.
Can I
Yeah.
add real quick?
Yeah, go ahead.
Dr. Finkelstein?
Yeah, go ahead.
Real quick, I would just say school-based care has also been a great place for behavioral health. And I know Avel does that as well, but with our tribal areas, it has been incredible to see the outcomes in those areas just because of the dynamics you talk about. The other thing I would just say really quickly too on a federal front is the residency component piece that was slated to go one way prior to the end of the PHE ending last Thursday, end of the day. So last Friday was the start of all the revert backs. And this was one of them that over the weekend was changed and now has been allowed to continue through this calendar year. So for us, that impacted a lot of our behavioral health providers as we have some residents as well. So they are overseen by our providers and then they can still provide those services to those patients. So we actually had to work other ways to get those patients in. So at the end of the day, what it all starts with is the patients, right? So now here we were this weekend calling patients, getting back on the schedule because that change had happened literally sometime over the weekend. So these policies at a federal level trickle down to patient access and satisfaction at the very, very local level.
Thank you. My name is Brett Hess. I am the Executive Director for the Western Association of Ag Experiment Station Directors, which has nothing to do with this panel, but I want to say this is an excellent panel. And so my question originally was about adoption, especially in light of early comments and the resistance by the traditional medical professionals. And it sounds like that's kind of the gist of this panel. You're concentrating, a lot of the discussion is on traditional. So my question originally was adoption by concierge service providers. Was that faster? Was there any data to suggest, because they broke the mold? But then recent comments about access and payment made me think, how does, in a broader scale, concierge service providers fit into the whole picture?
I can start with that. Yeah, so the model of direct primary care and concierge medicine, you're right. They were one of the forerunners because they utilized this. And what they're about, which is I think where things are headed, is asynchronous telemedicine. So what they've done is, because a lot of them are cash-based and they don't have to go through private payers and CMS and all the you-know-what BS from our messed up healthcare system, I had to say that, is that it allows direct communication between the provider and the patient, which is how it should be, right? To remove all the BS that has to happen between, the rules and regulations. So if a patient has a rash or has a lesion or one of my favorite tools is TytoCare. Do you guys use TytoCare?
Use Tyto.
So TytoCare is a great example of a handheld. It has multiple uses. So you can, if you are a mother or a father with 3 kids at home and they have an ear infection or a throat infection, it has a tongue blade attached to a high-def camera. You can look down the throat, send the image to the direct primary care concierge physician. They don't actually have to do it real-time, synchronous. It can be asynchronous. So when it's convenient for the patient and it's convenient for the physician, they can look at these pictures and send, give them a diagnosis or send a prescription electronically. So yes, concierge direct primary care is one way that physicians have thrown up their hands and say, I am madder in hell, I'm not taking it anymore, I'm going out on my own, I want to see my patients. and have that established relationship.
And I would say that our company is almost entirely subscription-based. So it's based on basically average daily census or average ER census. And so we have scaled to make it very affordable. So for most hospitals, it's less than a cost of a nurse. And you can call me 24 hours a day. You can call me 200 times a day. You can call me once a day, at any point. And then, especially for critical access hospitals, a lot of times they can take that off their cost reporting as well. So it has made it easy for that to be the right thing to do and to bring someone in that manner. Because billing we're in 29 states. We will allow them to bill on our behalf, but it's a lot.
What was the second part of your question after concierge?
Sorry, at first it was just adoption. So you addressed that, and then
Okay.
I was more interested on a broader scale, so I think that was the answer to just how concierge services might fit into it. One point that had not been addressed, though, was since you had mentioned copay or payments and receipt of payments for telemedicine, virtual medicine. The subscription model is one way to get around that, but insurance doesn't pay for that. And so I'm just curious what efforts might be underway to make it more equitable for the physicians who are offering care and trying to do the right thing to receive the same type of benefits that you might in a traditional setting.
I would say you need to send letters to your payers and our government and talk about those very real issues of payment and co-payments and how to take away those barriers, because really I think what the data is starting to come out. Although the private payers are always reluctant to share their information, but I think the elephant in the room is that telehealth and digital health is a huge cost savings to these companies, and they're not sharing in that pot of the pie. So it really has to come from the patients to say, you guys need to be offering these services ubiquitously and pay for them and have it as a benefit. Any other, we could go on and on and on for hours. Are there any other questions, and then we'll end it?
Jack's like, no.
Okay, I think we're done. All right, thanks guys.
Thank you.